Okay, this one is on chapter 69. This should go kind of quick. This is talking about the infections that can occur in the brain, some of the autoimmune disorders that can occur in the brain, and some of the cranial nerve issues. So let's get started. So the first thing I wanted to talk about is meningitis. This is probably it is for sure, but the most common of the neurological infections that you're going to encounter in your practice. So there's 3 different kinds of meningitis: bacterial, viral, and fungal. Bacterial meningitis is the most deadly of the meningitis. So when you suspect that your patient has meningitis, it is essential to find out what kind it is, and you do that with a lumbar puncture, and I'm going to get back to that in a second. So some of the meningitises can occur in dense populations. So you see it a lot breaking out in college dorms, like military bases where people are living in close quarters. That can create the spread of meningitis. Some other things that can cause it, like we've talked about earlier, is openings in the meninges, the cerebrospinal fluid that is contained in the meninges around the brain and the spinal cord. Breaks in that can introduce bacteria in there and can lead to a meningitis. So first of all, you start watching for signs and symptoms. Patients who have meningitis will complain of neck pain, headaches, photophobia. Photophobia means the light bothers their eyes. They can have seizures. They will have fevers. The fevers will last pretty much the whole course of the disease. Increased white blood cell counts. So if you find out that it is a bacterial meningitis, you've got to treat the patient with antibiotics very, very quickly, because the bacterial meningitis can kill, and they can kill very, very quickly. So you want to get them on antibiotics, and IV antibiotics stat. The other meningitises, the viral and the fungal, you really just offer support. So rest, fluids, good nutrition, and other supports, and usually the body then will be able to take care of that on its own, and you just treat symptoms, things to keep the fevers down, to have the patient feel better, things like that. So one thing that you want to do is identify it quickly. So when you start seeing some of these symptoms that I just talked about, you start seeing these showing up in your patient, you're going to want to do more investigation to find out, does this person actually have meningitis? There's 2 signs. There's a Kernig sign and a Brudzinski sign. Brudzinski is actually a little bit more of a sensitive indicator of meningitis. But this is what you do for your patient. You have them lay flat, and in the Kernig sign, you just pull their leg up and straighten it out, and in the Brudzinski sign, you start them out flat, then you have them put their knees up and then bring their head forward, and that'll also cause some pain. That's a really good indication your patient has meningitis. And then in combination with, are they starting to have fevers, high white blood cells, things like that, now you're really starting to suspect. Then you got to figure out what kind it is. The first thing we want to do is prevent it in the first place, and we've got a lot of good vaccines now where we didn't used to. So a lot of times what they're making college students do is get the meningococcal vaccine before they go into college dorms and stuff to prevent this, because now we do have a good vaccination for it. So then once you suspect it, the way to actually diagnose it is you have to do a lumbar puncture. The way that you do a lumbar puncture is you have your patient get in what we call a fetal position, where you round the back, you pull your knees up and your shoulders over. And what that does is it opens up these vertebrae up here, and then the physician or nurse practitioner, if you guys end up being NPs, will take a needle and you put it right into the cerebrospinal space, pull out some of that fluid, send it to the lab, and then they can figure out exactly what's growing in there and appropriately treat it. So if it's a bacterial, they start the antibiotics right away. If they find out that it's viral or fungal, they'll just treat symptoms and support the patient while they are recovering. Another thing that you're not going to see this very common, this is not a very common problem at all, but I did just want to mention that sometimes people can get a brain abscess. Typically your patient will get a brain abscess because of something else, like a sinus infection up here that erodes through into the brain. Sometimes tooth abscesses can go up and erode into the brain, and basically what it is just a pocket of infection in the brain. However, the signs and symptoms will be exactly as if this were a stroke or a tumor or something in this area. The patients will get confused, disoriented. It'll behave exactly like, you know, if there was any other kind of anomaly going on in this part of the brain. And this is what it looks like post-mortem. As you could just see, there's just sort of like this pocket of infection. It's really like just like a big zit in the brain. So one you want to identify, so you want to get a good history. Have they had a sinus infection, tooth abscesses, something like, get a good history. This will show up on CAT scan. This is a CAT scan. You can see these ventricles are actually kind of enlarged. This is starting to push. See how the midline is pushing this way a little bit? So it's creating some problems, and you can see there's some inflammation and stuff going on around here. And they can go in and drain this surgically. They put a needle in there and pull the pus out and flush it, you know, with an antibiotic wash or something like that if it's not resolving on its own. So that's a brain abscess. You may or may not ever see that in your practice. The next thing is encephalitis. There are a lot of different kinds of encephalitis. Your book talks about a bunch of different kinds. You don't really need to know all of the specific details of each of the kinds of encephalitis, but basically what it is just a diffuse infection in the brain. It can be caused from alcoholism, and we'll talk about this during hepatic week. You can have hepatic encephalitis. There can be a viral encephalitis. The herpes complex can cause herpes encephalitis. Mad cow disease. If you've heard of mad cow disease, it's really more of like a British thing. They call it mad cow disease, but that's a type of encephalitis. So there's different causes for it, but the outcome is the same, and it's basically just a diffuse infection throughout the entire brain. And you can see here, this is like the diffuse infection part, and then post-mortem you can just see it creates like this ugly infection in the brain. So that's what encephalitis is. Again, you want to identify it early, figure out the cause, treat the cause, and offer support, good fluid, pain management, things like that. So that's encephalitis. Now encephalitis is, you'll see it as like a secondary thing from a lot of other diseases. So now let's talk about the autoimmune disorders. There are several autoimmune disorders that can occur in the nervous system, and they're fairly common. Multiple sclerosis being the most common, we call that MS. That's very common. I'm sure you're going to see that in your practice, or you probably know somebody who's got MS. Myasthenia gravis, not as common, but has similar outcomes. And then your book talks about Guillain-Barré, which I will go into a little bit of detail about Guillain-Barré, but your book does not mention ALS, which is, I did kind of want to touch base on ALS, even though your book doesn't talk about it. It's more common than Guillain-Barré, but it's similar, so I wanted to tell you a little bit about that. So the first thing is multiple sclerosis. In multiple sclerosis, and if you'll remember, autoimmune disorders mean that the body starts attacking itself, and it identifies itself as the enemy, and so it starts destroying parts of itself. In MS, this is what happens. So you've got your nerve up here, this is up in the brain, it's getting some impulses from the brain, and then it travels down the nerves, and the way that the impulses travel down the nerves is through these myelin sheaths all the way down. So it just constantly transmits that impulse all the way down, if you remember that from physiology. So this is what a normal one looks like. Here's your nerves with the myelin sheaths. Well, what happens in MS is a destruction of this myelin sheath. And it can be, mild, and so they have very little symptoms, to almost a complete destruction of that myelin sheath, and then the patient is unable to move. So MS, what you'll see in MS, it typically shows up, in the 30, 40, 50 range, tends to occur to women more than men. And typically the patient just starts getting fatigued. So there's no cure for this, but what you want to do is prevent relapses, because what happens in MS is it's sort of like this trajectory like that, and over time, and people can live a long, long time with this disease, but as people live with it, and the symptoms will get worse and worse and worse and worse. Usually not exactly steady, like they'll have an exacerbation of it, and then they'll kind of be good for a while, and then they'll have another exacerbation of it. So it kind of is a stair-step kind of a disease. And the patients who have this, you want to keep them walking, because they can lose a lot of strength, they can lose a lot of mobility, so you want to identify it early. And then keep the patient active, but not super active. Like we're not having them run marathons, just like maybe go out for a slow walk every day, eat really healthy, stay hydrated, and get plenty of rest. So what you'll want to do is like group activity. So they get up in the morning, maybe make their coffee, and make breakfast, have a shower, sit down and rest for a while, then get back up and maybe run the vacuum or something like that, rather than just keep going, because fatigue is a problem. They tend to have a lot of problems with bowel and bladder. And another problem is heat. People with MS really can't stand extreme heats. And so if it gets really, really hot or really cold, their symptoms tend to get worse. So sometimes they need to just sort of be in a moderate climate, need to stay out of the sun and out of the extreme cold. So this is it's a debilitating disorder. There is some medications that kind of can help curb some of the symptoms, but we don't have a cure for it. So we just try to keep it at bay, keep the patients as healthy as possible with who have MS. There doesn't seem to be a genetic component to it. They're not sure what causes MS, but there's not really a genetic component. They think maybe people who have had exposure to Epstein-Barr, it's different in different parts of the world. Okay, this picture is not very clear, but this is an example of myasthenia gravis. Your book actually has a pretty good picture of myasthenia gravis. Myasthenia gravis is not as common as MS, so you're not going to see this a lot, but what happens in MS is you've got this same nerve cell coming up from the brain, trying to transmit through the nerve, and that part's fine with MG. The problem with MG is down here where these nerves come into the muscles. Now in a normal muscle, the nerves comes down in here it's got acetylcholine in it, and it triggers the muscle to contract. And so it has to deliver this acetylcholine in here for that muscle to do what the muscle is supposed to do. Well, in MG, there's a destruction of these the receptors in the muscle. So the problem with MG is actually a muscle disorder down in here, and the body actually is attacking these receptors that are waiting for this acetylcholine, so the muscle doesn't move. So what happens in MG is your patient gets very, very weak, and they fatigue very easily. This is very common in the ocular motor muscles, so many MG patients will start having muscle drooping, especially in one eye. The other problem with MG is when those respiratory muscles start getting involved, because then the patient can go into myasthenia crisis. And so you've got to be really careful to watch their respiratory status and make sure that they're still able to breathe, because that can be a huge problem with MG. Okay, so now the next thing is Guillain-Barré. So I'll talk about Guillain-Barré first because your book talks about Guillain-Barré. Guillain-Barré is peripheral nerve. It's the myelin in the nerve starts getting destroyed. Now in Guillain-Barré, it almost always follows a virus. So the patient will have a virus or some kind of an illness or something like that, and then anywhere between 2 and 6 weeks after, they start developing this unusual syndrome where they start getting weak and numb and inability to move, and it'll start in their feet and then it works its way up and it completely paralyzes the person all the way up. The problem is when it hits the respiratory status or system, it paralyzes the lungs, so the patients have to be on a ventilator. Now back in the day we didn't really have good treatments, so this disorder would last 3, 4, 6 months. The patients had to be in the intensive care unit because they had to be on a ventilator, and then as the disease progresses up, then it slowly starts returning, and then the patient heals and it leaves the body the same way it came. So now we have treatment, we can treat with IVIG, IV immunoglobulin, and plasmapheresis, where they do plasma exchange of the blood. Both of those are showing really successful outcomes and significantly shortening the course of Guillain-Barré. So usually it just lasts, 4 to 6 weeks rather than 3 to 4 months. So that's Guillain-Barré. But ALS is very, very similar to Guillain-Barré. The only difference is it's not reversible. So it'll start in the feet and it'll work its way up. It is a horrible, horrible, horrible disease. It's also called Lou Gehrig's disease. And most recently, you guys have probably seen that movie, A Beautiful Mind, with Stephen Hawkins. He has that. And the problem is that the mind stays extremely sharp, but the body just can't move. It's completely paralyzed. And it is a very debilitating, horrible disease. But the problem is just complete destruction of the nerves, and so the patient is just paralyzed. And they do end up having to be on a ventilator because of the inability to breathe. So those are horrible neuro disorders, autoimmune disorders. And then there are some nerve disorders. You should look over table 69.2 in your book. However, I really want to focus you on, there's just a couple of nerve disorders that are really common that you're going to see quite a bit. Basically, trigeminal neuralgia, that involves cranial nerve number 5, and Bell's palsy, that's facial nerve, and facial nerve is number 7. The difference here is trigeminal neuralgia is the trigeminal nerve that comes out from here and innervates the face. Very, very painful. It is extremely painful. So these people start losing weight because they don't want to chew. Even any little thing on their face just hurts really, really bad. It's typically temporary. People that have it once, it can come back. And in people that it's so bad, sometimes they have to go in and do surgery and just cut the nerve. Bell's palsy, it will scare you when you see it because it looks like somebody's having a stroke, because it usually involves just one nerve, like on one side, so cranial nerve number 7, and the face then starts drooping. The person has difficulty talking. Sometimes people who have had previous STDs and herpes are more prone to this, and usually people that have it once, it can come back later on. But typically both of these will go away over time. The other one that I wanted to tell you about was the peripheral neuropathies. We talked a lot about this when we talked about diabetes. Peripheral meaning, in the lower extremities, and that's just painful numbness, tingling from the nerves, and like in your diabetic patient, it's because those nerves have been bathed in sugar, and those nerves don't like to be bathed in sugar, but it will cause a destruction, and so then the patient can't feel their feet, or they'll feel like their feet are on fire. Those are the peripheral neuropathies, and typically those are associated with some other disorder like diabetes. So that's it. Okay, so see, this was a nice, quick, easy one. So just sort of focus on those things, and you should be good with this week. So, and next in chapter 70, we're going to do the cancers. So, okay.